Welcome to our next lecture for the annual clinical assembly of 2021. For this lecture, I have no financial disclosures. However, some of my slides and animation were provided by Zeiss. These are my sources, my references for this lecture. And the objectives of this lecture are to familiarize the audience with the procedure of small incision lenticule extraction, to introduce the pros and cons to implementing SMILE in your practice, and to learn what to expect with corneas in the postoperative period. This talk is about SMILE, small incision lenticule extraction. My name is William Sawyer. I'm a cornea specialist from Weatherford, Texas. And this talk is not a how-to lecture or a complications lecture or how to deal with difficult surgeries lecture. In fact, if you take up SMILE, I would encourage you to learn things from someone much more experienced than me. I'm a novice SMILE surgeon who just recently started doing this. And this is really more to let you know SMILE's out there, what it is, and the reasons you may or may not want to get involved with it in your practice. So what is SMILE? With SMILE, we're using a femtosecond laser to create a disc or a lenticule in the corneal stroma. This lenticule is then dissected anteriorly and posteriorly and removed through a very small incision, usually somewhere between 4 and 6 millimeters or 60 degrees. If you're in Europe, you can do it smaller or have multiple incisions, but not in the United States. What this does is allows the anterior cornea to collapse into the pocket that you've created, for the cornea to flatten into that pocket. And this helps eliminate myopia and astigmatism, and thus helping the patient with their refractive error. This is an animation provided by Zeiss, and it takes us through the steps of SMILE. First, a laser is used to create a posterior cut in the corneal stroma, then a side cut, which really wasn't shown there, and then a cut anterior. This creates a disc, a lenticule in the cornea. Now a small incision about 60 degrees will be created with the laser, and this allows the surgeon to reach inside and remove this lenticule. The cornea then basically collapses down onto that pocket that's been made. This flattens the anterior cornea and helps get rid of myopia and astigmatism, basically in the same pattern that an excimer does by flattening the cornea. Now, what was not shown there is that you do have to dissect the cornea. You cannot just reach in and pull out that lenticule like the animation showed. This is a diagram of the incisions that the femtosecond makes in the smile surgery. First cut is the posterior cut, also known as the lamellar cut. The laser works from posterior to anterior because as it goes, it will create small little gas bubbles, and these would get in its own way if it was going anterior to posterior. So first the lamellar cut is done, the posterior cut, and then the side cut is created. Then the anterior cut, also known as the cap cut, is created. In essence, you have now created the lenticule. And then lastly, the incision opening is created. This allows you to be able to get into the pocket from the surface and remove that lenticule. This is a little timeline of laser vision correction. PRK was approved in 1995, LASIK 1998, femtosecond 2001. SMILE was approved in 2016, but the first cases were performed in 2017 in the United States. And then October of 2018, SMILE gained approval for astigmatism treatment. In my mind, this is really where it started to enter the market because you could only do myopic spherical treatments before this date. SMILE is approved for treatments from -1 to -10 and for astigmatism from -0.75 to -3 with a spherical equivalent of no more than -10. Notice it is not astigmatically approved for 0 to -3, but from 0.75 to -3. It is also indicated for patients who are 22 years of age or older and who have a stable refraction. Unfortunately, in the United States, we do not yet have a hyperopic treatment, although this is being experimented with in Europe. So I lumped the contraindications under laser vision correction because they're basically the same as LASIK. Unstable refractive error, uncontrolled vascular disease, autoimmune diseases, immunocompromised, keratoconus, pregnant, other ocular diseases, uncontrolled diabetes, poor wound healing, cataracts, moderate to severe glaucoma, and any other contraindications that I did not think of, but you may decide on your own. However, these are really no different than LASIK, so that makes things a little bit easier. You don't have to remember, oh, this person has this health problem, so they can have LASIK but not SMILE. No, it's the same. It's the same. Before I decided to implement SMILE in my practice, I wanted to know, is it worth it? And what would be the advantages? Why should I do this? Uh, Things I came across were that it was very rapid recovery, as fast as LASIK, if not faster. There is no flap, which is really nice because it's more trauma resistant this way. This was probably one of the key things that I liked before I started doing any SMILE. Everything I had read says it's less likely to cause dry eye, and this is because it cuts less corneal nerves than LASIK. This is a slide provided by Zeiss that shows the corneal nerve plexus. And the corneal nerves, although they run throughout the whole cornea, most of them run in the anterior stroma. You can see on the second slide with LASIK, most of the time we're creating a 270-degree or more cut to lift the flap, and we're cutting through most of these anterior corneal stromal nerves. SMILE, because we're staying a little deeper and because our incision to get into the cornea is only 60 degrees, it cuts much less corneal nerves than LASIK does. In theory, this should lead to better sensation and less dry eyes in patients with SMILE. The disadvantages that I kept coming across were that you could not perform it on very thin corneas. The cap is 130 microns, so think of this like having a LASIK flap of 130 microns before you even get to the stromal bed. Some of these treatments with SMILE take more corneal tissue than an excimer treatment as well, so this is something to consider. There's no hyperopic treatment yet in the United States. Once again, there likely will be at some point, but not yet. And the platform is significantly more expensive than other femtoseconds on the market in the United States. We're going to come back to that in just a second. This is a slide provided by Zeiss, and this is the data from their FDA studies. And the first two bars in each of these graphs is SMILE. The first one is sphere only, the second one is spherocylinder. And as we can see, the visual results are very comparable to LASIK, even topographic guided LASIK, which the Alcon Contura is. Not only are the visual results comparable to LASIK, but the target is as accurate as well. As we can see across the board here, that it was very comparable to putting people within half a diopter of their intended refraction, and comparable with putting them within a diopter. Now I will tell you, this is Zeiss's data. They presented to the FDA. And so I'm sure you can find studies that show other percentages with the different lasers. However, every study I was able to come across in journals and on PubMed showed that its vision and targeting were very comparable to LASIK, and that there was a non-inferiority. This is its astigmatic treatment, and once again, very comparable to LASIK. So before I decided whether or not I was going to implement SMILE in my practice, I talked to many other surgeons. And these were kind of the common themes I got from surgeons who perform SMILE. Now take in mind, these surgeons already were performing SMILE, and most of them own their own laser, so their opinions were probably biased. Most of them told me they now converted most of their laser vision correction candidates to SMILE rather than LASIK. They really, really liked how the corneas looked post-operatively. They felt like they had less dry eye complaints from patients right away and over time. And many of them noticed that they had less retreatments with SMILE than with LASIK. In fact, some of the surgeons said they had a third of retreatments when they compared it to their LASIK. This is the opinion I got from LASIK surgeons who were not doing SMILE. Although the vision is not inferior to LASIK, it's also not superior to LASIK. It's not better than what's already out there. There's a significantly higher cost compared to other femtoseconds, especially if you already own a femtosecond laser for cutting flaps. The SMILE laser does cut flaps, so you can combine that, but I can tell you, when we were looking into this, on average, the SMILE femtosecond costs around $125,000 more than a different femtosecond, which could not do SMILE. You still need to have an excimer for many patients. In the United States, if you have a hyperopic patient you want to treat, or just anyone who falls outside of the parameters, the only way you can treat them is with LASIK or PRK. Plus, if you needed to do a touch-up for SMILE, you cannot repeat SMILE. You have to touch it up with either PRK or thin-cut LASIK. Also, you're starting over with a procedure when you're already very confident with the procedure you have at hand. This, of course, takes a lot of time to learn a new procedure, and if it is not necessarily superior to the one you were already doing, is it worth taking this on? So what I ended up doing, I went with Smile because first of all, I at the time owned no laser vision correction lasers at all. So I was going to need to buy a femtosecond anyway. And this allowed me to offer a little different niche in the market. I can now offer every laser vision correction treatment there was. I also bought the topographic guided excimer so I could market that I had the most advanced technology with femtosecond and Smile, and also with my excimer and topographic guided LASIK. The laser for Smile also creates unbelievably nice LASIK flaps when you use it for that as well. It also allows me to expand my surgical skill set. My old program director, when I was a resident, Dr. Robert Peets, would tell me when he was doing a procedure that took longer than a cataract and paid less than a cataract, the reason he did this was because he did not want to become a one-trick pony, because you never knew when the surgery or the skill you were using would become outdated and replaced with something else. So it was always good to have to diversify your surgical skill set. As a corneal surgeon, this also appealed to me because I like to be able to perform all kinds of different surgeries on the cornea and keep up my skills in different ways. The path to my first Smile case was kind of rough. I bought the lasers in the fall of 2019. You have to do 50 LASIK flaps with this laser before the company will allow you to do your first Smile case. And this is wise. You want to make sure you're comfortable with the laser and that you know how to center it well on eyes before ever doing Smile, because centration is very important. Also, this allows you and the rep time to fine-tune the settings for the laser. Your settings have to be much more precise to have a good Smile treatment than they do to have a good LASIK flap treatment. I was about to do my very first case and COVID hit and shut us down. Now, I was just starting laser vision correction in my market, and I did not have a large referral base at the time, and so our recovery from COVID was very slow when it came to refractive procedures. Actually, not cataract, but laser vision correction refractive procedures. And so I did not get to perform my first case until October of 2020. And I would like to show you my very first Smile case ever. And this will allow you to see what the surgery is real and to see a person doing it for their first time. The first part starts with the femtosecond, lining up the eye. And here in a second, we'll see the meniscus when it starts to touch the cornea, and we'll suction on. This laser provides less suction than most lasers, so it's more comfortable. It also suctions on more anteriorly, right at the limbus and onto the cornea, which is also more comfortable for patients and leads to less subconjunctival hemorrhages. And that was the posterior cut that we just saw. Now it's doing the side cut, and then the anterior cap cut is going on right now. Unfortunately, it's going to cut off on my screen, but the incision was just done inferiorly. As soon as the laser is done, it will release the suction and you can move the patient back. You move them over to this second microscope at the same laser. You don't have to move them off the bed for this. That was a proparacaine soaked wax cell I was using to numb up the conjunctiva so that I have a place to hold the eye and hold it steady. I'm now opening up my incision, which, like we talked about, is about 60 degrees. This ends up being 4 to 6 millimeters in length. I am now dissecting anterior to the lenticule, and there's a way they teach you to do this. Now I'm going to start a dissection posterior to the lenticule, and so that I can define my planes. Some of the biggest problems happen when you get confused as to whether you're in the anterior plane or posterior plane. So I'm going to start out in my anterior plane way over to the right where I didn't even make a posterior dissection, so I know where I'm at. I've sped this up 2 times so that I don't bore you as much with this, but yes, this procedure took me twice as long as what you're watching. So I'm dissecting the anterior portion right now. Femtoseconds work by creating small perforations like postage stamp perforations, but on a microscopic level. So you do have to go in and break these small adhesions between the tissue. This is a blunt dissector. I'm now posterior, and that's why I went in that left side so that I didn't confuse myself where I was. They teach you to leave 2 little tags when you first start, and this creates a little tension and a little resistance while you're dissecting to make your dissection easier. Now I'm breaking those tags, and I should have created a full dissection now. This is the first time I've ever used these forceps, and they did not work quite as I was thinking they should. You had to open them much wider than I was comfortable with, and it took me a little time to figure out how to get both anterior and posterior to that lenticule. Once I figured it out, I was able to go across, grab the lenticule, and remove it. Then place it on the cornea, and I'm going to now spread this out to make sure that I've got the entire lenticule, to make sure I didn't leave any small little pieces which could lead to some very irregular astigmatism and poor refractive results. You want to spread this out, make sure all your edges are nice and clean, there are no big notches, and everything was good there. They teach you to irrigate the pocket, but I will tell you there's definitely controversy whether you should do this or not. Some people say don't irrigate unless you see any debris, but I was taught you should irrigate, and this is my first case, so that's what I'm doing. Irrigating the pocket. Now I'm going to squeegee that BSS back out of the cornea. Make sure everything is smooth and the pocket is collapsed. That's a wet weck. And left a little tiny fiber on my cornea over to the right side, which I will now grab with some forceps and get that off of there. And now it's time for drops, and the case is over. And this is my patient post-op day 1. You can see the cornea just looks great. It's hard to tell anything there. Now I'll tell you, under the slit lamp, you can tell where the smile treatment was. This was taken with my iPhone through the slit lamp, so, you know, I feel like this was a pretty good picture, but it's not a professional camera setup. The vision of this patient was 20/20 the first day, and he was exceedingly comfortable the first day, but also the night of the procedure too. Here are his corneas 1 week later. Same 20/20. You can see I was able to capture the small incision to get into the smile pocket on his superior cornea, so you're able to see that. But besides that, the corneas just look regular. They look very, very impressive. This is the patient 1 month later. He's actually 2015 at this point. And I really like this picture because I was actually able to catch the interface with the camera. You can see the small line just under the corneal surface, and that is the smile pocket. That is where the lenticule was taken from. So these are the things that I've really liked about Smile and about my patients afterwards. The corneas look very good, even in the immediate post-op. When you take them from the laser to the slit lamp, they already look very, very good. The patients are comfortable, very comfortable, and not just further out, but right away. I tell most LASIK patients that they're going to be irritated for about 4 hours after surgery, and then they'll start feeling a lot better. With Smile patients, I still tell them that, but truthfully, most of them tell me they had 0 to just extreme mild irritation uh, um, the first few hours and no irritation the next day. They really are quite comfortable. They also seem to be more comfortable farther out from treatment. I agree with the other Smile surgeons. It seems like I see less dry eye problems with Smile. A number of my patients tell me they're not using their tears because they don't feel like they need them. I emphasize they should be using them, but still, they say, hey, they're not feeling it. I am less worried about trauma in these patients. The stromal pocket wants to collapse right where it should be. There's very low chance, without something sharp cutting the cornea, that anything could really be dislodged. And this is something I have to deal with my LASIK patients. I know I just had a LASIK patient not too long ago who got kicked in her eye less than a week out from surgery. In fact, I want to say it was only 3 days out from surgery by her 2-year-old. Thankfully, she just got a corneal abrasion and it did not dislodge the flap. But I have also seen a patient that 15 years after LASIK, she was in her garden and cutting roses, and a stem got under her LASIK flap and pulled it up and left debris. And I ended up having to lift the LASIK flap and irrigate all the debris out and treat her for a long while to get her back to doing well. And she is doing well. But this would be very unlikely to happen with Smile. Now, I will say that was a microkeratome LASIK flap. That was not a femtosecond that she had. What I do not like about Smile, it is more surgically demanding than LASIK. The dissection is definitely more difficult than just dissecting a LASIK flap and reflecting it. In fact, I find the hardest part of LASIK nowadays to be getting iris registration with the laser, not the actual physical part of LASIK. There's definitely more to explain to patients. Instead of only explaining PRK and LASIK, I now have to explain a whole third procedure and the benefits and disadvantages to each of them, which one I would recommend for them. It also competes with my own topographic guided LASIK. The topographic guided LASIK, I do feel like gives you the best higher order aberration profile. In other words, I feel like it gives you the best night vision that any of these treatments can give you. And I own a topographic guided LASIK excimer. So a lot of times it's difficult to tell someone whether they should have top of the line LASIK or Smile. I let their complaints of dry eye guide me a lot there, their age, and um, uh, how much nighttime activities they do. Um, there are a significant number of patients that just plain cannot have Smile. They have too thin of corneas to have it. I don't like taking more than 40% of cornea. And I'm including the Smile cap to be part of that. The treatment perimeters won't allow a lot of patients. Hyperopes, for instance, just anyone who falls outside of any of those treatment parameters um, cannot have Smile. One thing that I didn't list on here because it's not true on every office, but because I went with two different brands for the femtosecond and the excimer, I cannot just swing patients from one laser to the other on the same bed. I have to move them from one bed to the other. Now the beds are right beside each other and it's not a very big deal, but it still slows you down a little bit and is annoying. Some of the complications that you can have with Smile. Intraoperatively, you can have vacuum suction loss while you're trying to treat with the laser. You can have a decentered treatment. The lenticule may adhere and not want to come out. Or you could just get an incomplete lenticule removal, leave part of it in the pocket, which is very not good. You can have incision tears or cap perforations. You can leave debris in the interface or have epi defects. And I'm sure there are a number of other complications that I could not think of or did not come across in my studies. Postoperative complications. You can over or under correct an eye. You still can have dry eyes with this. You are cutting some of the corneal nerves. Patients can get infections. They can have ectasia. You can also get diffuse lamellar keratitis with this procedure. And on an especially big treatment, you can get corneal stria, so you have to watch out for that. You have to make sure that the pocket lays down exactly like it should. So we're going to go through a few of my cases that did have problems. I have experienced diffuse lamellar keratitis. Now, this is something reported with LASIK, and it's felt that it is a sterile, most of the time sterile, highly inflammatory problem that you get at the flap interface, which can lead to poor vision and scarring in extreme situations. I had a 23-year-old male. His left eye was the one that developed diffuse lamellar keratitis. That's why I only have it listed. I treated both eyes, but the right eye never developed DLK. Uncomplicated Smile, first day, 2015. But then he returned for his 1 week visit, and he stated he was noticing some mild double vision or at least ghosting of images in his left eye. And his vision had dropped from 2015 to 2025. And this is what I saw on slit lamp. This is a little video I'll show you. So once again, done with my iPhone. I apologize about the glare, but you can see these multifocal white spots through the cornea. And I believe that is probably the path that my forceps took to grab the lenticule when I removed it. That looks just like how those forceps look there. This is easily causing all of the symptoms that he's having with the ghosting and the decreased vision. He was not having any pain, redness, or light sensitivity really to speak of. So SMILE DLK, it's thought to be the same inflammatory process as LASIK DLK, as classic DLK. The incidence is somewhere between 0.45 and 1.6%. Most of the time it will resolve with topical steroids. You hit them hard with topical steroids. And you will see multiple focal sterile inflammatory spots. It looks different than the classic DLK with LASIK. It looks like those very focal spots like I showed you in the video before. The treatment is pretty much the same as classic DLK. You want to hit them hard with steroids at first, and if you're getting no improvement or not satisfactory improvement, then flush out the interface. The literature I came across said you should have even a lower threshold for irrigation with SMILE, although I couldn't tell exactly why. So I hit my patient really hard with steroids. We did Durezol every hour while awake. And at 1 week, he had very mild improvement. He noticed the vision slightly improving. When I looked at his cornea, as you can see in the picture, it did not look any better to me. So I was definitely very concerned. I kept him on the steroids, just trying everything there while I figured out what I wanted to do. I kept a close watch on him, and he was not worsening at all, and he would report mild improvement, but it was pretty unimpressive. And so finally, in a month, I got tired of this and I said, we need to flush this. And so I flushed out the SMILE pocket with BSS at 1 month. It was surprisingly easy. The incision allowed you to just go right back in and you could flush quickly. It was very, very quick. He was not very uncomfortable afterwards. And as you can see, the next day he was back to 2015 with great improvement in the doubling of his vision. This is the cornea the very next day. We can still see small little spots where the infiltrates were, but they were nowhere near as impressive as they were before. And obviously, just his vision and symptoms have greatly improved. I kept him on steroids actually for a few months afterwards. I lowered him down to 4 times a day and just slowly tapered him, and he's done great. He's still 2015 and just doing great. I've also recently run across my first undercorrection case. I had a 43-year-old male who was a contact lens wearer for over 20 years. He had been out of his contacts before this for over 2 weeks, and his refraction was stable from what he'd had in the past and what his contacts were. Minus 175 plus 50 in the right, minus 2 plus 50 in the left, 20/20. He underwent uncomplicated SMILE procedures OU, but the very next day he came in and he was 20/40. He was not using his steroids, so we had to reprimand him there and get him on the correct dose or the correct medications. And we thought maybe that was the reason he was 20/40. Maybe he had a little extra inflammation and there was some anterior stromal edema that was keeping him down. That was the theory. kept a close watch on him. And even at 2 weeks, he was still just 20/40 and not moving at all. I decided to flush the pocket just to see if perhaps the anterior cap had laid down incorrectly into the pocket and maybe I could smooth that out. It was really kind of a Hail Mary, but I flushed the Smile Pockets OU, which was once again quite easy to do and very uncomplicated, and he was quite comfortable afterwards. Blurry because I flushed him pretty good. But unfortunately, even 1 month out, his vision was just not where I planned for it to be. He was 20/30 uncorrected OU. His refraction was -1 plus 25 in the right eye, -150 plus 1 in the left eye. It nearly looks like we basically did nothing with this guy. There was a mild treatment. I mean, if you remember, he was a -175 in the right eye to begin and a -2 in the left eye to begin, but still, that's a very unimpressive treatment. So, uh, all I can think of with him is that he was such a long-term contact lens wearer. He may have been a patient that I needed to keep out of his contacts for a month or multiple months before having the procedure, and that his corneas were just not as stable as I thought they were. Um, that's really the only thing I can find. I've reviewed my cases, my videos with it. I've had the company look at the laser settings and the videos and everything looks just fine. There was also other Smile cases done on that same day, and all of those cases were just fine. So, a little hard to say what happened. So at this point, what am I going to do? Well, I'm going to let him stabilize. At this point, I'm not going to touch him till he's about 3 months out from the procedure, and he's fine with that. We've discussed all of this. He's a fairly reasonable guy. After that, I cannot perform Smile again. That's one of the problems with Smile, and one of the reasons you have to have an excimer. If you try to perform Smile again, you might accidentally cut oddly into your old pocket and come out with a lenticule you did not intend to get. So you can either do PRK on top of Smile, which this is probably what I will try to talk him into, or you can do thin cut LASIK. You can basically do a 90 or 100 micron flap, and you want to make the hinge nasally so you don't accidentally put the hinge right where your Smile incision was and create a free floating flap. And this can be used to retreat and get rid of the prescription. My guess is that is what this patient will want to do. But of all my Smile cases so far, and I don't have a ton like we talked about, this is the only one that I'm going to have to retreat. I'm sure there will be more in the future, but I have not had many at all. Now, my review of Smile. I agree with the surgeons that have been doing Smile. There is definitely less discomfort with Smile than there is with LASIK, although there's not much discomfort with LASIK either. There's less discomfort with dry eyes, at least in the short term, than there is with LASIK. The visual results are excellent. I'm getting just outstanding visual results, and I would say it's the same as LASIK. Neither one is superior, neither one is inferior. There's definitely a rapid recovery. People are seeing better vision even faster than my LASIK cases, at least in my practice. And I definitely do have more peace of mind. I feel like there's less chance of something happening where a patient can damage their eyes afterwards. Those fingernails to the eyes or things like that that could definitely lift a LASIK flap. are just so much less likely with this. You really would have to have a bad injury or something sharp cutting the cornea, I feel like, to have a bad injury with SMILE. In conclusion, I would say most likely if I already owned a femtosecond and was doing LASIK, and there was not a big niche for SMILE in my market, I would not have purchased this laser and started doing SMILE. However, it did work for me because I was starting out fresh and had to buy all the lasers anyway. And there's very few people doing SMILE around my area, so it does fulfill a niche in the market, uh, which helps my laser vision practice. It's also something that I just plain enjoy doing, which, as we all know, that leads to bigger happiness with our own practices. Thank you very much for paying attention and for joining me in this lecture, and I will be around during the Q&A to answer any questions that you might have.